Hi there and welcome to this video brought to you by Atoza. My name is Garth. This is our third video on airway management in this course aimed at the learning anaesthetist. In the first airway video we discussed how to assess an airway and how to prepare our airway equipment. In the second airway video we looked at some of the technical aspects of managing an airway, including mask ventilation, insertion of a supraglottic airway, and then a standard endotracheal intubation. Now, in this video, we're going to continue to look at some of the technical aspects of airway management. Those will include how and when to perform a rapid sequence induction and intubation, how to manage patients that are at risk of rapid desaturation, how to manage the airway in a shocked or unstable patient. And then we're also going to look in detail at an airway management algorithm to help us when we are experiencing difficulty in managing an airway. And the algorithm that we're looking at is the vortex model for airway management. Following on from this, we're going to discuss emergency front of neck airways and look at the technical skills for performing a surgical cricothyroidotomy. And then I will talk about how I use video laryngoscopy in my practice and some of the technical skills related to this. And then lastly in this video, although it isn't core knowledge, I will walk you through how I use awake video laryngoscopy in certain patients as part of my airway assessment or for definitive awake airway management. So I hope you enjoy this video lecture and let's get into it. So we ended off the second airway video by looking at the standard approach to endotracheal intubation. Now let's start this video by looking at a rapid sequence induction and intubation. So first of all, you may be wondering why it's called a rapid sequence intubation. Well, it's really simple. It's because the steps of induction of anesthesia, paralysis, and then intubation are performed in a rapid sequence. Next, you may be asking, well, why do that? Or how does that differ from a normal induction of anesthesia? So the main indication for a rapid sequence induction is patients that are at risk of aspiration of gastric contents into their lungs, which could lead to mechanical obstruction of the tracheobronchial tree. It could lead to chemical pneumonitis, and then later on it could lead to a bacterial pneumonia. There is a second indication for a modified type of RSI, and that is in patients who are at risk of rapid desaturation. But we'll discuss that a bit later. So what are the key features of an RSI compared to a normal induction of anesthesia? Well, firstly, the induction agent is given in a pre-calculated fixed dose as a rapid push and not titrated to level of consciousness as one may do in a normal anesthetic. Secondly, the muscle relaxant drug is given immediately after the induction agent, without delay or any attempts at mask ventilation first. Thirdly, the dose and the type of muscle relaxant used is potentially different to a normal anesthetic. And there are two main options here. We can either use succinylcholine or scoline at a dose of 1 milligram per kilogram of ideal body weight, or we can use high-dose rocuronium at a dose of 0.9 to 1.2 milligrams per kilogram ideal body weight. Fourthly, laryngoscopy and intubation is performed as soon as possible, which is, in the case of scoline, immediately after the fasciculations have occurred. And if we're using high-dose rocuronium, we can perform laryngoscopy and intubation 60 seconds after the rocuronium is given. Okay, so now that we know some of the basics of a rapid sequence induction. What is the rationale behind it? Well, the aims are twofold. Firstly, to have the patient paralyzed as quickly as possible so that active vomiting is not possible. Vomiting requires muscle strength. So if you're paralyzed, you can't vomit. And then secondly, to have the patient asleep and paralyzed as quickly as possible so that intubation can occur as rapidly as possible. And then once the patient is intubated with an inflated cuffed tube, the airway is as protected as it can ever be from vomiting, from regurgitation, or from other contents such as blood entering the lungs. So in summary, RSIs are all about protecting the lungs from the risk of aspiration. Okay, so we've discussed some of the key aspects of an RSI, but is there anything else to this technique? Yes, there are some other important things we need to discuss too. Those include reducing the stomach contents and reducing the acidity of the stomach contents, either through using antacids, through using stimulants that promote gastric emptying, and then from using gastric tube mechanical drainage of the stomach. We then also need to discuss patient positioning for an RSI. We need to discuss cricoid pressure. We're going to talk about mask ventilation during an RSI. And then we're going to talk about managing emergence from anesthesia after we've done an RSI. So now let's look at each of these points individually. Firstly, the point on reducing gastric contents and the acidity of the gastric contents. So where possible, it is ideal to try and reduce the volume of the gastric contents and to reduce the acidity of gastric contents prior to the performance of an RSI. This can be done by giving the patient 30 ml of sodium citrate to drink immediately before coming into theatre, and this will neutralize some of the gastric contents. We can also give the patient 10 milligrams of metoclopramide intravenously within 30 to 60 minutes of coming to theatre, provided that there are no contraindications like bowel obstruction or a previous sensitivity to metoclopramide. And this will facilitate emptying of the stomach into the duodenum and the small intestine. And then for more planned elective procedures, we can give the patient 24 hours of proton pump inhibitor before coming to theatre. And again, this will raise the gastric pH, will make it less acidic. So these basics are often overlooked, but they are very important and they can improve your safety significantly. But what about the use of gastric tubes like a nasogastric tube? So the rationale behind using a gastric tube is to mechanically drain the stomach of its contents before the anesthetic, so that if vomiting or regurgitation occurs, there is less of it. But there are a few issues that we need to consider with this. So firstly, the insertion of nasogastric tubes is quite uncomfortable for the patient, and it significantly adds to the stress of the anesthetic event for the patient. Next, nasogastric tubes do carry a risk of airway trauma that can complicate your airway management. And there are some patients that really don't tolerate the insertion of the nasogastric tube well, and it's quite a struggle. It can be quite difficult, and with repeated attempts, you can definitely get significant bleeding in the airway, which you don't want. Then nasogastric tubes block really easily, especially if there's particulate matter in the stomach. And so they may not actually drain the stomach as much as you think they are draining it. And then lastly, nasogastric tubes disrupt the lower esophageal sphincter tone while they're in place. And then even if you inserted one and took it out straight away, that lower esophageal sphincter can be disrupted for, I think, up to about 30 minutes after removal of a nasogastric tube. And so they can actually make the risk of regurgitation higher. So inserting nasogastric tubes just for the performance of a rapid sequence induction is a bit of a gray zone. In my practice, what I do is I do insert nasogastric tubes preoperatively for very high risk patients, such as those with gastric outlet obstruction or bile obstruction. And then also in trauma patients who are clearly intoxicated from alcohol consumption. But I don't insert them for every patient that's at risk of aspirating and vomiting, because I think the risk-benefit evidence is just not there. Okay, so we've spoken about draining the stomach and reducing the acidity of the stomach contents. Let's now discuss positioning during a rapid sequence induction. So you may think that having your patient in a head-up position will help to prevent aspiration of gastric contents, as the contents now have to travel up the esophagus against gravity. While in theory that might be true, that it's more difficult for that content to travel up the esophagus, if vomiting and regurgitation does occur, and that vomitus or gastric content does reach the pharynx, it's now downhill into the trachea and into the lungs, which we don't want. And so that's why the classic position for preventing aspiration is a head down position, and actually a head down left lateral position, so that any regurgitant or vomited material can drain out of the pharynx and the mouth easily. And for this reason, I don't have my patients head up when I'm doing a rapid sequence intubation. I rather have them supine. And in fact, I have the remote control or the controls of the table ready to immediately place that patient in a head down Trendelenburg position if they do regurgitate or they do vomit. So start with them supine, but be ready to put them head down. The idea of turning a patient into the lateral position is a good idea, and I think it really depends on where you are in the anesthetic. So if someone vomits before you start your induction, you're getting ready to start the anesthetic and someone vomits, then definitely turning them into a lateral position head down is the thing to do. Or during emergence, either prophylactically waking patients up in that position, or if they vomit during emergence, to put them in a head down lateral position. But once I've started to give my induction drugs, if they regurgitate or vomit from that point, I'll put them head down, Trendelenburg, but I won't turn them lateral, because I actually want to focus on management of the airway, focus on suctioning out that airway and getting an endotracheal tube in as quickly as possible, rather than turning the patient lateral at that point. Okay, so just remember it like this. The recovery position, which is the head down left lateral position, is the safest position for someone who's vomiting or regurgitating. Let's now move on to cricoid pressure. So cricoid pressure is external pressure on the cricoid ring of the trachea, normally by the anesthetic assistant, to force the cricoid ring posteriorly onto the esophagus and to try to occlude the esophagus. So you push backwards on that ring, and internally you are squashing the esophagus. And this will help to prevent any passively regurgitated gastric contents from reaching the pharynx. Cricoid pressure doesn't prevent active vomiting. Only rapid muscle paralysis can achieve that. So there are also some controversies with the application of cricoid pressure. There are numerous studies showing that cricoid pressure is actually quite poorly performed in terms of whether it's applied at the correct level, so whether the assistant is actually pushing on the cricoid ring or pressing too high or too low, whether it's done at the right pressure, which is meant to be 30 newtons, and then also whether it's done in the correct direction, which is directly posteriorly onto the esophagus. So this, combined with the fact that it's well known that cricoid pressure impairs your view at laryngoscopy, has led people to question whether it should be done at all. It's going to make intubation more difficult, and it might not be done properly in any case. So what do I do in my practice? Well, to start with, I go through the technique with my assistant before we do it. I explain to the assistant why we're doing it. I indicate where on the trachea I want them to push, and I talk about how hard they must push and that they must push straight backwards, hopefully onto the esophagus. Then I do use cricoid pressure as the patient is going off to sleep, because I think it does add some benefit. And I continue that cricoid pressure right up until the laryngoscope is in the patient's mouth. And then at that point, while I'm performing laryngoscopy, I can decide whether to continue with the cricoid pressure or to release the cricoid pressure so that I can get a better view of the larynx. So in other words, my patients will have the benefit of 45 to 60 seconds worth of cricoid pressure, and that may just prevent regurgitation and aspiration. But at the point of intubation, I most often release that cricoid pressure so that I can get the tube in quickly and smoothly and inflate that cuff as rapidly as possible. Okay, so I feel this way the patients get the best chance of benefit with the least chance of harm. So now, what about mask ventilation during a rapid sequence intubation and induction? Well, the classic RSI avoids mask ventilation because of the risk of gastric distension, which can lead to regurgitation and aspiration. But there are certain times when I would still mask oxygenate or gentilate. And this is the first time we've used this term in the Airway talks, which is gentilate or gentilation. And it's a combination of gentle and ventilate, and we've got gentilate. So gentilation is low volume, low pressure mask ventilation aimed just at maintaining oxygenation. And the patients who will benefit from that are patients who are at risk of faster desaturation, and we'll discuss that soon. And then if my first attempt at intubation is unsuccessful, I want to gentilate between attempts to prevent desaturation. So the important point here is that if you are mask gentilating, that you want to keep your pressures as low as possible, and that means good technique. You need to perform a chin lift, you need to perform a jaw thrust, and you need to have a low threshold for inserting an oropharyngeal airway, because all of those will help keep your pressures low. So remember that the risk of vomiting and aspiration in these patients extends into the post-operative period, especially at emergence and extubation. And so in these patients, we need to consider inserting a nasogastric tube during the anesthetic to drain the stomach, extubating these patients fully awake, which means that we don't have any doubts or concerns about their level of sedation or paralysis, and that their airway reflexes have returned to a near normal state. And then extubating these patients in the left lateral head down position, so that if they do vomit or regurgitate, that content doesn't easily get aspirated. So now let's briefly discuss who might require this rapid sequence induction and intubation that we've been talking about. And in my mind, there are three categories of patients. The first group of patients are those who are not starved. And that is patients that have had something to eat in the last 6 hours, or they've had clear fluids in the last 2 hours. And these patients in my practice are normally either trauma patients, where they've had an unexpected injury, but they can also be patients with acute life-threatening problems like bleeding post-surgery, or another example is pregnant patients who are in labor and now have a complication of their labor and need to come for an emergency cesarean section. So that's patients that are not starved. The next category is patients who have mechanical obstruction to their GIT system, either gastric outlet obstruction or intestinal obstruction. And we know that these patients are at particularly high risk of aspiration because they can actually get retrograde peristalsis and extra fluid and possibly even fecalant material moving up the intestines into the stomach, and they can have a large volume of this material in their stomach. And then the third category of patients is patients that have delayed gastric emptying for another cause, not obstruction, another cause. And the classic examples here would be patients with intra-abdominal sepsis, such as a perforated appendix or a perforated diverticulum or gastric ulcer. There's no bowel obstruction, but there is intra-abdominal pathology or sepsis that is going to cause an ileus and reduce gastric emptying. And so these patients are at risk of aspiration. And then there are also medical causes of delayed gastric emptying. And one of the most challenging ones is the diabetic patient. So we know that diabetic patients are at risk of diabetic neuropathy, and that can affect their motor and sensory function, but it can also affect their autonomic function. And so their normal gastric emptying isn't happening. And so diabetic patients can have a larger residual volume of food or liquid in their stomach after they've starved. And that can put them at risk of aspiration. And to detect this clinically, you need to have an idea of how to assess these patients for signs and symptoms of autonomic neuropathy. But that's a different talk. We're not going to focus on that now. But just to be aware that certain medical patients can also have delayed gastric emptying. So those are examples of patients who need a rapid sequence induction and intubation. Okay, and then just to conclude this section on RSIs, let's talk about the downsides. And there really are two main downsides of a rapid sequence induction and intubation. Firstly, our induction agent is given as a pre-calculated fixed dose, which may result in underdosing and the risk of accidental awareness, or it may result in overdosing and the risk of hypotension. We won't go into this in more detail in this video because we cover induction agents in detail in the video on intravenous induction of anesthesia. And then the second downside relates to the muscle relaxants that we're using, which is either succinylcholine with all of its side effects, or it's high-dose rocuronium, which will have a prolonged duration of action. Again, we cover this in detail on the talk on muscle relaxants, so look out for those videos. Right, so that concludes my take on rapid sequence induction and intubation. There's quite a lot to it. Let's move on now to the management of patients who are at risk of rapid desaturation. So you'll remember that the theory behind pre-oxygenation is that we can buy up to 8 minutes of apnea time at induction of anesthesia before the patient starts to desaturate. And that is really quite amazing, and that's a fantastic safety net. But that's the theory. In practice, there are many patients who will desaturate much faster than this. And this includes pregnant patients because they have an increased metabolic demand and they also have raised intra-abdominal pressure. It includes obese patients due to raised intra-abdominal pressure. Patients with bowel obstruction, again, raised intra-abdominal pressure. Pediatric patients because of their higher metabolic rates. And then other hypermetabolic patients such as those with burns or sepsis. And then obviously patients with lung disease, which affects their ability to fill their functional residual capacity with oxygen. For example, patients with a severe pneumonia. So how do we make induction of anesthesia and airway management in these patients safer? Well, there are a couple of steps that we can take. So firstly, we want to consider the positioning of these patients. In patients with raised intra-abdominal pressure, it can be useful to have them in a 15-degree head up or reverse Trendelenburg position. And that basically just reduces the abdominal pressure on the diaphragm and so reduces the chances of lung collapse or atelectasis. Then with these patients, we can also apply PEEP of 10 or 15 centimeters of water to the mask while we are pre-oxygenating them. And that will just help keep those lungs expanded while they're lying supine and they're being pre-oxygenated, and it will reduce the chance of collapse. And if you're lucky, it may actually even cause a bit of alveolar recruitment during the pre-oxygenation phase. The next thing that we can do is we can perform a type of rapid sequence induction and intubation, or something that people might call a modified RSI. And the principle behind this is to go through the induction phase as rapidly as possible to allow early ventilation and intubation, and to take control of the airway and the ventilation as soon as possible. And this will reduce the period of hypoventilation, and it will also reduce the apnea time. And in practice, this would look very similar to a conventional rapid sequence induction and intubation, except the focus is on ventilation, not on preventing aspiration. And then while we are doing this modified rapid sequence induction, you can start to support ventilation as early as possible. So as the patient is breathing spontaneously, you can actually watch their chest rise, and you can support each of their spontaneous breaths with the bag and the mask. Remember, you've got some PEEP applied already, so your APRV valve is closed a bit, and you can support each breath. And then as the patient becomes unconscious and then becomes paralyzed, their minute ventilation will drop off, and then you can continue to gentilate or gently ventilate these patients. And then lastly, what you can do, which might be a new concept to you, is you can apply apneic oxygenation. And one can do this quite easily by using nasal prong oxygen on the patient during the induction process. So while the patient is still awake, you apply the nasal prongs and you have them running at 4 liters a minute. And then you pre-oxygenate the patient as you would normally do with the bag and the circle system. And then as soon as the induction drugs are given, you turn up the flow rate on your nasal prongs to 15 liters per minute. So now there's 15 liters per minute of 100% oxygen entering the nasal cavities, the pharynx, and the hypopharynx. And this oxygen can move down into the lungs by diffusion and by bulk flow. And it can significantly help reduce the chances of desaturation during the apnea time while you are managing the airway. So that is apneic oxygenation. And then just as an aside from this, in very high risk patients, and if you're working in a center that has the facilities available, you could actually use high flow nasal oxygen in this situation. So not nasal prongs that peak at 15 liters per minute. You get nasal oxygen delivery systems that can give 100% oxygen at 60 liters per minute. So now you've got 60 liters a minute of oxygen going down into the lungs by bulk flow and diffusion. And they really are fantastic at preventing desaturation. And I frequently use these devices in the ICU setting when we are intubating patients there. And often the patients are already on these high flow nasal oxygen devices, especially during the COVID pandemic. There were lots of patients on the devices. But even now, we have patients on them, or I put the patient on the device specifically for my airway management. And that can significantly prolong my apnea time and make my intubation and airway management safer. Right, so in summary, that's how I manage patients at risk of rapid desaturation. Let's now briefly look at airway management in the unstable patient. So unstable patients will most likely need an RSI for 2 reasons. They could very well be at risk of aspiration, and then also they are most likely at risk of rapid desaturation because of their high metabolic rate, because they are shocked. So a rapid sequence or modified rapid sequence induction and intubation may very well be warranted. But there are a few other points I want to highlight regarding these patients. Firstly, you want to use an induction agent and dose that is going to be as safe as possible for these patients and not cause cardiac arrest on induction. And I would go with ketamine in most cases. Secondly, you want to have inotropes pre-drawn and ready, including adrenaline, so that you can correct hypotension rapidly. Thirdly, Use an endotracheal tube in these patients. Don't use a laryngeal mask airway. And then lastly, this is a particular group of patients in whom we need to worry about carbon dioxide levels during our airway management. Up until now, we've emphasized oxygenation over ventilation during airway management. But in unstable patients who are likely to already have a metabolic acidosis, we need to prevent respiratory acidosis. And often we actually need to maintain higher than normal minute ventilations and aim for low carbon dioxide levels to balance the metabolic acidosis. So these patients are at risk of worsening acidosis during our airway management and then cardiac arrest from severe acidosis at induction of anesthesia or intubation in the ICU. And so we have to maintain their hyperventilatory state. If you take a patient in septic shock who's breathing at a respiratory rate of 35 breaths a minute, and then you make them apneic for a period of time, and you turn on the ventilator and you ventilate them at a respiratory rate of 10 breaths a minute, their carbon dioxide levels are going to go from low, they might be sitting at 3 or 3.5 kPa, to high normal of 6 kPa. And that just might be what pushes them over the edge from an acidosis point of view. So this is one of the few groups of patients in whom we aim for full ventilation and possibly even hyperventilation during our airway management. And then we want to aim to secure the airway with an endotracheal tube as soon as possible. And then when we switch on the ventilator, initially aim for hyperventilation again. And then obviously if you're in a setting where you can do blood gas analysis, you can titrate your ventilation according to your CO2 level on the gas and your acid-base balance on the gas. But if you're in a setting where you don't have acid-base monitoring, then you need to aim to hyperventilate these patients and probably aim for an end-tidal carbon dioxide level of around 4.0 kPa. Okay. So far in these talks on airway management, we focused on all the things to try and improve our chances of successful airway management, all of the technical skills, all of the things we can do to improve our technique and our safety. And this has included airway assessment, it's included planning for your airway, getting your airway equipment ready, improving your airway techniques and skills. And now we have to discuss in more detail what to do when our airway management is unsuccessful. So I've hinted at this a little bit in each step. What can we do to improve mask ventilation? What can we do to improve supraglottic airway? What can we do to improve laryngoscopy and intubation? But there are actual guidelines on what to do when you are struggling with your airway management. And there are two sets of guidelines that I use in my practice. So the first one is from the Difficult Airway Society, which is often referred to as DAS. People talk about the DAS guidelines. And these are fantastic guidelines and algorithms for airway planning and management. And I really recommend reading these guidelines and these algorithms and understanding them and having them as part of your framework and your guide and how you manage your airways. But for me, practically and clinically, and for the purposes of this talk, the second set of guidelines that I really like is the vortex model for airway management. And I'm going to use this one to go into detail to try and explain to you how to manage airways when you are having difficulty. So DAS guidelines are excellent, but we're not going to go into that detail today. We're going to focus on the vortex model for how to manage the airway. So the vortex model is a very simple model to guide your airway management in theatre. There are only 3 non-surgical options for airway management, which are bag mask ventilation, supraglottic airway, or an endotracheal tube. And these are depicted in blue in the center of the vortex towards the top of the vortex where the vortex is still wide open. One can move between these three options in any direction at any time, with the understanding that at each new attempt at one of the three options, something different has to be done to improve your chances of success. So there's no set rules in terms of you have to go from mask ventilation to supraglottic airway to endotracheal tube. You can go in any direction. One is then allowed a maximum number of 3 attempts at each option. But again, you have to do something to improve or to change your approach for your next attempt. Just repeating the same thing over and over again is going to get you into more trouble. It's not going to work. So some of the things that you could change would be, firstly, manipulations, such as manipulating the patient's position, putting them into a ramped position, which is also known as the head elevated laryngoscopy position or HELP position. People also talk about it as sniffing the morning air position. Other manipulations that you can do are manipulations of the larynx externally by applying burp, which, as I said earlier, is backwards, upwards, rightward pressure of the larynx by your assistant. And if you're using cricoid pressure and you're struggling, you should release the cricoid pressure to try aid your next view at laryngoscopy. And this is because the risk of a failed intubation or failed airway is much higher than the risk associated with vomiting or aspiration. So those were the manipulations you could do. Then there's some adjuncts that you can use. So I've spoken about how I enjoy using the gum elastic bougie to assist my intubations. You can also use malleable introducers or stylets inside the endotracheal tube. And then one can change the equipment that you're using. You can change the size or type of your airway device. You can use a completely different type of airway device altogether. You can change between a nasopharyngeal airway or an oropharyngeal airway. Suction is something that they also recommend as an adjunct to help you while you're struggling with the airway, to remove secretions and blood from the airway and to aid your view. And then another thing you can do if you aren't doing apneic oxygenation from the start is you can add in apneic oxygenation during your airway manipulation. You can see that you're struggling, that your first attempt at intubation wasn't successful. And so now, get the nasal prong oxygen, put it on, and at least have that benefit of added oxygenation for your second or third attempts. It will buy you more time, it will prolong your apnea time, it will make you safer. And then, as I've said before, something that was controversial previously but is now accepted in airway management is adding muscle paralysis to your airway management. If you take away that muscle tone, you might just find that mask ventilation or use of a supraglottic airway and then intubation is going to be much easier if the patient is paralyzed. So those are some examples of the things that you can change or try to improve to make your next airway attempt successful. And they are part of the vortex model for airway management. So let's get back to the vortex shape. So what the vortex model is showing you in the vortex shape is that with each unsuccessful attempt between mask ventilation, supraglottic airway insertion, or intubation, you spiral further and further down the vortex into the danger zone. The danger zone being hypoxemia, hypercapnia, and a situation where you can't intubate and you can't ventilate the patient. And you have a completely failed airway, and your only available option is to perform an emergency front of neck surgical airway. So that's if you're unsuccessful during your attempts. So the other scenario that the vortex model allows for is that if you have success during any one of your attempts at any of the 3 airway options, and now you are able to oxygenate the patient and to some extent ventilate the patient, then you can rise up through the vortex and enter the green zone where the patient is relatively safe because you have an airway technique that is working and you are able to oxygenate the patient or hopefully even fully ventilate the patient. And now you have two choices: to abandon the surgery and wake the patient up, or to continue with the surgery with your current airway in place. And this will largely depend on the context that you're in. So for example, if you have a patient that has a severe fetal distress and has come for an emergency cesarean section, and you've failed to insert a spinal anesthetic, and so now you convert to a general anesthetic, and you're unable to intubate that patient, and your supraglottic airway is not working, it's leaking, you just can't get it to work nicely. But with a Goodell airway in place and a face mask, you are able to easily ventilate that patient. This is a potentially life-saving surgery for the fetus. And in this situation, I would feel comfortable continuing with the surgery and delivering that fetus while mask ventilating the mother, because it's going to be relatively short surgery. Like I say, it's going to have a massive impact on the well-being of that baby, and the mother is in a supine, a safe position. Yes, she would be at risk of regurgitation and aspiration. Hopefully you've given the sodium citrate to neutralize her gastric contents, and you've given metoclopramide to aid the emptying of the stomach. But I think one would be totally justified in continuing with your anesthetic like that. The same would be in a patient who comes in with a stabbed abdomen or a perforated appendix, and now you've only been able to get a supraglottic airway in for this patient, even though they're having a laparotomy. These are sick patients that need life-saving surgery, and waking them up and then waiting to transfer them to another hospital or waiting hours for experienced staff to come and assist you, that might not be an option for these patients. And so continuing the surgery with a laryngeal mask airway in situ is a totally reasonable thing to do. In these cases, a second generation supraglottic airway would be an excellent option, because you can pass a gastric tube through the port down into the stomach, and you can decompress the stomach from any air or gastric contents that may be there. So those would be situations where one could possibly continue with the surgery. Examples where you wouldn't continue with the surgery would be big elective procedures, like an elective hemicolectomy or an elective hip replacement or something like that, where you've struggled with the airway and you have a suboptimal airway device in for that particular patient for that surgery. Then you would wake the patient up and rather plan for their surgery at a later stage. Now, with the understanding that this is a difficult airway, you've learned some lessons from what happened this time, and next time you, with the help of a senior colleague, can tackle this airway in a different manner. Sometimes patient positioning would also play a role. So if you've been unable to intubate a patient, but you are able to ventilate them with a supraglottic airway, but the surgery requires that you turn this patient prone so that their pilonidal cyst or abscess near their buttocks can be drained, I would rather wake that patient up and come up with a different anesthetic plan than take the risk of turning the patient prone and performing the surgery with a supraglottic airway in when it's your only working option. So the context does really matter. How urgent is the surgery? How close at hand is help or expertise? Can someone get there and help you within the next 15 to 20 minutes, or are you going to have to wait longer than that? Or are you even going to have to refer that patient to a different center? So those are some of the things at play in making this decision about abandoning the surgery, waking the patient up, or proceeding with your current airway in place. So important things to not forget with the vortex model, that even though you are allowed 3 attempts at each technique, every new attempt carries the risk of trauma to the airway, causing bleeding and swelling of that airway, and placing that patient at risk of complete airway compromise and a can't intubate, can't ventilate scenario. And so you want to make sure that your first attempts are your best attempts. The next thing is that every second or third attempt, we need to change something to try and improve our chances of success to get a better result. Repeating the same actions won't result in success, but they will result in progressive trauma, edema, and put you in a very dangerous situation. Remembering at all times that you can easily change an airway in which you are struggling, but you are still able to oxygenate, into an airway which is impossible to manage in any way, where you are unable to oxygenate and is immediately life-threatening. So in the event that you are having increased difficulty at maintaining oxygenation of the patients, don't wait for hypoxemia or cardiac arrest before moving to the surgical airway. Once your saturations drop below 90%, you're on the steep part of the oxygen dissociation curve, and the saturations could be 60 or 30% within a matter of seconds. And then this has the very real risk of progressing to a hypoxic cardiac arrest in someone in whom you can't ventilate. If you're doing CPR on them, you know you can't get air into their chest because you've been trying and you failed. So don't wait for that situation. Act early. You know that your attempts are unsuccessful, and before the saturations start to fall below 90%, you need to convert to a surgical airway. So with that in mind, let's now tackle the topic of the rescue surgical airway. So just some background. When I was doing my training a few years ago, I always thought there were two options at the front of neck airway or the rescue surgical airway. The one was to do a needle cricothyroidotomy, where you insert a cannula through the cricothyroid membrane and you then ventilate through that device. And I've actually had to do that in my anesthetic career so far. And fortunately, it worked, and it was a life-saving intervention. The other option was an open surgical cricothyroidotomy, where you have to make an incision on the neck, you need to cut the cricothyroid membrane, and then insert an airway device directly into the trachea. And I always thought that actually the needle cricothyroidotomy sounded easier, and it sounded like it should be my go-to front of neck airway approach. But actually, the gold standard for front of neck airways is the surgical or open cricothyroidotomy. And that is because it's much easier to teach, and you actually have better control and a better feel for where you are inserting the device, compared to the needle cricothyroidotomy, which is a closed procedure, and it's quite difficult to know that you are inserting that needle or that cannula into the right position. So with the surgical cricothyroidotomy, they talk about a three-step approach, or teaching a three-step approach. And it's also called the knife, finger, bougie approach. And for an excellent description and an actual video on how to perform a surgical cricothyroidotomy, I recommend that you check out the website for Life in the Fast Lane, because that website's got excellent information on how to do this approach. Okay, so the technique that is described is, obviously you want the patient in a position where you can access the front of the neck, which is why I keep emphasizing that from the beginning, have the patient in the optimal position. Because now, once you're struggling, now to try get pillows and things under the shoulders and under the neck and the head to try bring out a short closed neck into a neck where you can actually palpate things. Like, you don't want to be doing that at this time. But the patient has to be positioned in a way that you can actually access the neck. So what's described is with your non-dominant index finger, which would be my left index finger, I palpate the anatomy to identify the cricothyroid membrane. Okay, and that's the membrane between the thyroid cartilage and the ring of the cricoid cartilage. And then with my dominant hand, which is my right hand, I hold the scalpel and I make a 4 centimeter longitudinal top to bottom incision over that area where the cricothyroid membrane is. It's a big incision so that you have space and you have access. And this is a life and death scenario. You don't want to make an incision where you're just gently cutting the skin and you haven't really even penetrated into the deeper tissues. This needs to be a single cut, deep incision through the skin and the little bit of subcutaneous tissue that's there directly onto the cartilage of your trachea and your larynx there. Okay, so non-dominant index finger, feeling where the membrane is, dominant hand, 4 centimeter deep cut over that area. Then with your non-dominant index finger again, you can feel through this incision. There's going to be blood, there's going to be bleeding, it's going to bleed. You can put your finger through this incision now and feel directly onto the cricothyroid membrane. This is why it's important for that first cut to be deep. Because if your first cut isn't deep enough, when you put your finger there, you're still going to be feeling some of the subcutaneous tissue. So you're aiming to get through all of that tissue with your first cut down onto the actual trachea. And so now your index finger is positioned on the cricothyroid membrane. And then with that same scalpel in your dominant hand, you're going to stab through the cricothyroid membrane and you're going to make a 1 centimeter horizontal incision through the cricothyroid membrane. Okay. Obviously, you've got to be careful that you don't cut your own finger. So you're palpating and you move to the side and then you put that scalpel through the cricothyroid membrane and you make your cut. You don't remove the scalpel. At that point, you now turn the scalpel into a vertical position again. So you've made a horizontal cut through the cricothyroid membrane. You rotate that scalpel so that it now is changing that cut and it's opening up that cut. So the scalpel is turning and actually opening the incision that you've made in the cricothyroid membrane. Okay, and the scalpel now is the guide for where you need to aim with your bougie. So now you're holding the scalpel in your dominant hand, you can take your gum elastic bougie and you can pass it through that incision that you've just made. And the scalpel is the guide for where to aim so that you don't lose your hole. And that bougie is now going to be advanced down into the trachea. You can remove the scalpel and now you're going to railroad the size 6 endotracheal tube over the bougie and down into the trachea. And I've never done this, but I imagine that when you get the tube down to where the actual hole is in the trachea, it might require some twisting. It's probably going to require some lubrication with some water-based lubricant. There will be some blood there helping you, but some lubrication. And to twist that endotracheal tube and advance it into the trachea, to then inflate the cuff of the endotracheal tube and remove the gum elastic bougie. You're then going to connect your breathing apparatus to the patient, whether it is an ambubag or whether it's your breathing circuit, and you're going to bag ventilate the patient, paying careful attention to, is their chest rise? Is the tube misting? And then most importantly, what does my capnograph trace look like? And you want to see at least 6 waveforms on the capnograph trace. Front of neck airways have a relatively high risk of misplacement. So you actually go lateral to the trachea or you go into the other tissues and you're not in the trachea. So this is a scenario where you want to be absolutely certain that you are in the trachea. If you're not in the trachea, well then you have to take that device out, palpate through your incision again, try find the cricothyroid membrane, and then start again with the scalpel and trying to get your bougie into the right place. And bearing in mind that if now your airway has gone in the wrong plane, the patient is at high risk of a unilateral or bilateral pneumothorax. So if they deteriorate subsequent to this, then you must always think, have I caused a pneumothorax? So that is the approach to the surgical cricothyroidotomy, the three-step approach, the knife, finger, bougie approach. And it's something that maybe you'll only have to perform once in your career, maybe never, maybe twice. But when you do have to perform this technique, it is immediately life-saving or potentially a life-threatening situation. And so this is something that you want to have prepared for mentally, well in advance. You want to know this is exactly what I'm going to do. I've thought about it. I've visualized. I know that this is what it's going to feel like when I make that cut. I know there's going to be blood, but I've got to cut deep. I know that I have to cut at least 4 centimeters so that I give myself enough space to find the actual cricothyroid membrane. It's going to be really scary then perforating with the scalpel and cutting laterally, but I have to do it. And then I must remember, don't take out the scalpel, keep it in there, twist it so that I can get the bougie in. It's just something you got to go through in your mind over and over again. Know exactly what you're going to do. And this is why in the airway preparation talk, I talk about checking the emergency airway trolley, that they have everything needed for an emergency surgical cricothyroidotomy, a scalpel and a bougie and a size 6 endotracheal tube. And if they don't have that, get that equipment together, label it in a packet and put it in that airway trolley. Know exactly where it is so that when you need it, it's ready. Okay, so that's the surgical cricothyroidotomy. Once the size 6 endotracheal tube is in situ, what do you do then? Well, again, for life-saving emergency surgery, you need to proceed with that surgery. Obviously, you've now got a definitive airway in place. And for non-life-saving surgery, you can then abandon and do the surgery at another time. You have potentially caused quite significant trauma to the airway. So if you've had to do this technique, definitely the safest thing, transfer to an ICU setting and let surgeons and anesthetists and intensivists with more skill and experience in managing this then tackle the airway and wake that patient up when the time is appropriate. It would be an absolute disaster to have a successful surgical cricothyroidotomy and then wake the patient up, remove that tube, and then have bleeding or another complication that immediately threatens that airway and threatens that patient's life again. Okay, so now we've covered the techniques for mask ventilation, for insertion of a supraglottic airway, for laryngoscopy and intubation, and then we've also covered the surgical cricothyroidotomy. In addition to this, we've covered the vortex model for airway management, and we've discussed the various steps to improve our second and third attempts at airway management. So just before we finish off this talk on airway management, earlier in the talk I said I would explain how I use video laryngoscopy in my practice, and I would go through how I do awake video laryngoscopy to help my practice. So firstly, regarding video laryngoscopy, there are multiple different devices available, and they differ significantly in price and, unfortunately, quality. It's important that you practice on the device that you have available to you on routine airways so that you're comfortable using the device with its strengths and limitations in an emergency situation. What I've noticed, especially about some of the less expensive devices that I've used, is that they fog up really easily and you get a blurred view where it's actually of very little help. And to overcome this, you can warm the laryngoscope blade in hot water before using it. And it really does work. The two issues with this, though, are you firstly don't want to overheat the laryngoscope blade because this could lead to airway burns. And so I wouldn't use water that's more than 40 degrees Celsius. And then secondly, if you are reaching for this device in an emergency situation, then you might not have the hot water available in theatre to pre-warm it and use it. And then it's going to fog up. And that's a serious downside of the less expensive devices that have this problem. The next big issue with video laryngoscopes is that I'm yet to work in a theatre complex that has a video laryngoscope available in each theatre. So the device is shared between multiple theatres, which can affect theatre efficiency. When you have a patient in theatre and you're wanting to use the video laryngoscope but someone else is using it, the patient's now on the operating table and you're waiting for the device to be used and then cleaned and then brought to your theatre. It can also have a big negative safety impact because the device may not be available in an emergency situation where you're struggling to oxygenate the patient, and then video laryngoscopy might just be the thing that gets you out of trouble, but someone else is using it. So this brings me to the debate of whether we should be using video laryngoscopes for all our intubations. Well, clearly, if there's only one device shared between 5 theatres, this just isn't possible at all. And in fact, using the device unnecessarily, okay, so I say unnecessarily in inverted commas. So you have a patient where routine laryngoscopy would probably be fine, but now you've chosen to use the video laryngoscope because you know your success is going to be better and the patient's going to have less of a sore throat afterwards. You've got less chance of damaging their teeth. So you've chosen the video laryngoscope because it's the best thing for your patient, even though a normal laryngoscope might be adequate. You've now taken that video laryngoscope away from being used in neighboring theatres that might actually need it in an emergency situation. And so it's actually quite difficult. How do you, in a busy theatre complex, how do you decide who gets the video laryngoscope, who doesn't, who waits, who goes first? And then what happens if you need it in an emergency and it's not there? I do think, though, that there is little doubt that video laryngoscopy is superior to normal laryngoscopy in terms of its success rate and in terms of the reduced likelihood of trauma and pain for the patient. Okay, so that's some of the background. The next thing you need to decide if you're going to be doing video laryngoscopy is the size and type of blade that you're going to use. And here I would make the case for always, and I mean this, always using the D blade, which is the difficult airway blade. It's the blade that's got the extra curve on it. It's more curved than the normal blade for difficult laryngoscopy. And what the D blade allows you to do is it allows you to see the larynx when it's more anterior, when you would normally just see the epiglottis and you wouldn't see the vocal cords at all. So it's excellent in that scenario. But it still can be extremely difficult to intubate these patients. You get a great view of the larynx, but to actually get the endotracheal tube now to advance anteriorly and go through the larynx is what's difficult. And you may need to put a curved stylet in the endotracheal tube, or you might need to use a gum elastic bougie to get the endotracheal tube in the right place. So you might be saying, well, if the D blade gives you a good view of the larynx, but intubation might still be difficult, well then why use the D blade? Well, the D blade is the blade that's going to get you out of trouble when you're using a normal laryngoscope and you can't see the vocal cords. It's the blade that's going to make visualization of the larynx possible and then give you a chance of intubating the patient and actually passing the endotracheal tube into the trachea. You want to practice using the D blade as much as possible before you are required to use it in an intubation where it really is a life and death situation, where you're struggling to oxygenate that patient and now you're trying to intubate the patient to secure the airway. And this is because you need to learn how to manipulate the actual blade in the hypopharynx, to manipulate the vallecula and to try to get your best view of the vocal cords. You also need to learn how much to bend the stylet and how to manipulate your endotracheal tube so that you can manage the curvature that's required to get to the vocal cords. And then you also need to practice how to manipulate your bougie so that you can have the right bend on it so that you can get to the vocal cords. Unfortunately, the difficulties don't end there. We've said that using the D blade video laryngoscope can give you an excellent view of the larynx, but make intubation difficult. And so we've said, well, we can use the D blade to get a view of the larynx, and then we can manipulate our endotracheal tube with a stylet or with a bougie to try now get the tube to approach the vocal cords. But actually passing the endotracheal tube through the vocal cords when you've got it right there is very difficult in these situations too. And that's because it's often an anterior larynx, and now the endotracheal tube has had to go quite posteriorly and then come up towards the anterior larynx, and the angle of approach is totally wrong. Ideally you want to be coming into those vocal cords, on the same plane as the trachea. You want to be coming in, straight down the trachea. And here we have a situation where the trachea is like this, the tube is coming up like that, and now we've got to get it almost to straighten and go down the trachea, all the way down there in the back of the throat. And there's further manipulation that is required here. So what I do in these situations is very variable. If I'm using an endotracheal tube with a stylet, then often what happens is the stylet and the endotracheal tube will then get caught on the anterior aspect of the larynx, and one won't be able to advance it further. And then under vision, while holding the endotracheal tube, I'll get my assistant to slowly pull back on the stylet. Here again, lubrication is incredibly important, because if it's difficult to get that stylet out, which it will be because it's got a steep curve on it, and if it's not lubricated properly, you're not going to get the stylet out. So you need lots of lubrication on it. So now I'm holding the endotracheal tube against the larynx. It's not in the perfect position. And the assistant can then start to remove the stylet. As the assistant does that, the endotracheal tube tip will now become a little bit more flexible. And then still holding it in that position, I can start to maybe twist the tube, or sometimes I have to remove the stylet completely, now holding the tube, which has lost some of its firmness, against the larynx, and then slowly twist the tube, and then also ask my assistant to manipulate the larynx externally, a little bit to the left, a little bit to the right, downward pressure, upward pressure, and try to get to a position where this tube that's touching the anterior aspect of the larynx can then drop into the larynx, and then you can advance it down the trachea. So that's if I'm using a stylet. If I'm using a gum elastic bougie, like I said earlier when I was talking about intubation, I like to overflex the gum elastic bougie. So it's flexed more anteriorly than what I need it. Can then advance it into the airway. And by the time we get to the vocal cords, normally that bougie is starting to unfold a little bit. And I can then get it towards the vocal cords and wait for it to unfold, and then try to advance it down into the trachea. Again, some external manipulation can help there too. Sometimes with the gum elastic bougie, I'm just not able to get it down the trachea, but I am able to get it wedged up against the larynx, and then I can pass the endotracheal tube over the bougie down towards the larynx, and now wedge the endotracheal tube against the larynx, remove the bougie, and then I'm in a similar situation as what I was with the stylet, where I now have the endotracheal tube touching the anterior bit of the larynx, and with external manipulation of the larynx or twisting the endotracheal tube, I can get it to go down. If I'm a bit luckier than that, I'll actually get the elastic bougie down the trachea, and then, like we described in the section on routine intubation, one can then, together with the assistant, pass the endotracheal tube down towards the larynx, and then try to manipulate the endotracheal tube and the larynx externally so that the tube is not catching on the arytenoids or on the vocal cords, and then advances down into the trachea, and then we can remove the bougie under vision. So using a video laryngoscope in routine airways, excellent, because it's going to reduce your chance of airway trauma, your chance of pain, and it's going to improve your success. Using the video laryngoscope in difficult airways means that you can see part or all of the vocal cords when normally you wouldn't be able to see it, but getting the endotracheal tube in can still be very difficult. And so this requires a lot of practice. And so that's why I say always use the D-blade, because then you're always going to be practicing with the piece of equipment that you're going to use in that emergency situation, and you're going to get more and more comfortable with manipulating your stylet and manipulating your bougie. Okay, so that's how I use the video laryngoscope to intubate patients where routine intubation is difficult. Let's now move on to the advanced airway topic of awake video laryngoscopy. If you remember at the beginning of the talk, I emphasized that this talk is really focusing on essential airway skills and not on advanced airway skills. And then I also said that there are a number of advanced airway techniques, and many of them are in awake patients, because with the patient awake, you have a whole added level of safety for your airway management. So possibly the gold standard in awake airway management is awake fiber optic intubation using a flexible bronchoscope. This is a very specialized piece of equipment. It's extremely expensive, and it requires a lot of skill and practice performing this airway technique, and it's unlikely to be available in resource-limited settings. But as video laryngoscopes become more common in theaters, and as there are new devices that are created and they become more affordable so that doctors can buy them themselves or hospitals can buy more video laryngoscopes, awake video laryngoscopy is something that can really help you in your airway assessment while you're trying to work out how you should manage the airway, or in awake video laryngoscopy guided intubation. So I've done this a couple of times, and so I'll talk you through my technique. So awake laryngoscopy is obviously going to be uncomfortable because we're now putting the blade of the laryngoscope into the patient's airway, and they are likely to gag and cough and bite down on that laryngoscope. And certainly if one goes too deep towards the epiglottis and the vocal cords, it's going to be extremely unpleasant for the patient. So we have to topicalize the airway. And the simplest way to do this is to get the patient to rinse their mouth and gargle with lignocaine. So I use the intravenous lignocaine formulation, 2%, so 20 milligrams per ml. And I ask the patient to put the lignocaine in their mouth, to not swallow it, but to rinse their mouth with 5 ml initially. So the patient will swish that around their mouth. And I'll ask them to do that for maybe 20 seconds. And then I'll ask the patient to gargle with that same lignocaine in the back of their throat. So then the patient can gargle, and then take a break, and then swish it some more in their mouth, and then gargle again. And they probably need to do that 3 times, 20 seconds with each maneuver. By that point, most of the upper airway is going to be anesthetized. One can then, with the patient supine in a ramped position, start to insert the video laryngoscope, again using the D blade. And I will have a xylocaine spray in my right hand and the video laryngoscope in my left hand. The xylocaine spray is a 10% spray, and each spray delivers 10 milligrams of lignocaine. And so as I'm slowly advancing the video laryngoscope into the airway, if the patient has any discomfort, I can slow down, I can bring the laryngoscope further back, and I can spray 1 or 2 sprays of xylocaine in that area, wait a little bit, and then advance the video laryngoscope further. And so I'm going to try to advance that video laryngoscope all the way down to the epiglottis and the vallecula. As we get deeper into the airway, it's almost certain that one is going to need to spray with the xylocaine into the hypopharynx, into the vallecula, and onto the epiglottis. You don't necessarily want to spray onto the vocal cords at this point because you're still just doing an airway assessment. So then we can get the video laryngoscope into the best view possible for that patient. And we can see what grade view of the larynx we get. Now what we can do is we can say, well, we've got a good view of the larynx. How easy will it be to get an endotracheal tube into the trachea? So you can take your gum elastic bougie and you can insert it into the airway, and you can approach the vocal cords. Try not to touch the vocal cords, but approach the vocal cords. And quite quickly now I can get a feel. I've got a really good view, and I can see this is going to be really easy to get through the vocal cords. The tip of the bougie is right there. The angle of approach is right. This looks relatively easy. And then I can use that information to say, okay, I think with this information now of the best laryngoscopy view that I can get in an awake patient, I think it's now safe to do in a sleep technique in this patient. I'm going to put them to sleep. I'm then going to go to laryngoscopy with the D-blade, insert the bougie, and insert the endotracheal tube. Obviously, for all the sleep techniques, you need to have a backup plan. You can't be reliant on just one technique. We've emphasized that again and again. There always needs to be a backup plan. But this will at least allow you to know that I think intubation is actually going to be easier than what I suspected. Okay, so that's the one approach. In certain patients, I might take this even further, where say I don't have a backup plan for a second airway management option, where really mask ventilation, front of neck, supraglottic airway, they're all going to be difficult. And I'm doing a awake video laryngoscopy to see if awake intubation is possible. So we'll get to that same position where the video laryngoscope is in place and the elastic bougie is there, and it looks like awake intubation in this patient is going to be possible. At that point, I'll take all the equipment out of the airway, okay? I will then do a transtracheal injection of some lignocaine. So you have to feel the trachea and then with a small needle, perforate through the trachea and inject 2 mL of lignocaine into the trachea. The patient will cough and splutter, but that lignocaine in the trachea will now anesthetize the inside of the trachea, and it will also anesthetize the underside of the vocal cords. So we do that and we wait a little bit of time for the patient to settle, and then we can go in again with our video laryngoscope and get to our best position again where we can see the vocal cords, and now bend the xylocaine spray and go in with the xylocaine spray too, and now spray directly onto the mucosa around the larynx and then onto the vocal cords themselves. Here again, the patient will cough and splutter a little bit. As you're doing that, you might then need to take the video laryngoscope out, let the patient cough and deal with the fact that you've just irritated their vocal cords. Wait 60 seconds for the vocal cords to start becoming anesthetized. And then now we're ready to try an awake intubation on this patient. And so again, in with the video laryngoscope, in with the bougie, and now try advance the bougie through the vocal cords into the trachea, and then railroad your endotracheal tube into the trachea. So this is an advanced technique. It requires skill, expertise, and it requires confidence because it's something that is totally out of the routine. The patient will never have heard of this type of anesthetic before. It is quite uncomfortable for the patient, and you're in a situation where if it doesn't work, well then you have to abandon the surgery and you have to refer the patient somewhere else. So there's quite a lot of stress involved in doing this. But I think in resource-limited settings, if you're in a situation where a group of doctors have pulled together and they've bought themselves a video laryngoscope, or you've managed to raise funds at your hospital to have a video laryngoscope, and now you have a patient where you're not certain, they're in the gray zone. Should I do standard asleep airway management for this patient? Is it going to be safe? Or should I refer this patient to a center where they have the skills and expertise to manage this more difficult airway? Well, then if you have the video laryngoscope, you have the lignocaine, you have the xylocaine, then you can do this approach and you can get quite a good feel for what laryngoscopy is like. And then you can decide, okay, it's safe for me to go ahead with a sleep technique, or you can potentially do a full awake video laryngoscope guided endotracheal intubation. So if during our awake video laryngoscopy, we cannot visualize the vocal cords, or perhaps you can even see that the airway is very distorted from scarring, from edema, then you know that this is an airway that is out of your skill set and you need to get the patient referred to a center where they can manage this patient safely. But awake video laryngoscopy can help you make that decision. So the purpose of this talk is not to make you an expert on this, but just to give you an overview of how it is possible to do awake video laryngoscope guided endotracheal intubation. So just for completeness sake, if you are going to be applying lignocaine to the airway as a topicalization to achieve anesthesia of the airway, the maximum safe dose is 9 milligrams per kilogram. And so while you are doing this approach, you have to remember how much lignocaine you have used. Right, so that concludes the 3 video series on airway management for the learning anesthetist. I would just like to finish off this video by summarizing the 3 airway presentations that we've had in this series and try to bring them together as a comprehensive approach. So firstly, when you go to the ward to assess the patient preoperatively, you should already have some understanding of what surgery they're coming for and the requirements of that specific surgery for your anesthetic and for your airway. So how long will the surgery take? Short surgeries under 2 hours are quite well suited to using a supraglottic airways, whereas longer surgeries tend to necessitate an endotracheal tube. Are there any position changes that will impact on my airway management? For example, a steep head down or steep Trendelenburg position may make positive pressure ventilation with a supraglottic airway more difficult. The prone position probably also necessitates an endotracheal tube in most cases, because a supraglottic airway is more likely to be malpositioned when you turn the patient, and then managing the airway in the prone position during the surgery will be extremely difficult. Laparoscopic surgery also tends to necessitate an endotracheal tube. Then we can ask ourselves, how stable will this patient remain during the surgery? In surgeries where we're expecting significant blood loss, it may be better to aim for the control of an intubated, ventilated patient. So before we even see the patient, we already have some idea of what our airway management is likely to be. We can then perform a clinical airway assessment on the patient, always with the endpoints in mind. And these are the questions: will I be able to mask ventilate? Will I be able to use a supraglottic airway? Will laryngoscopy and intubation be easy or difficult? And will a front of neck rescue airway be easy or difficult? So, after clinically assessing the patient and asking yourself these questions, you should now really have a good feeling for the airway requirements of the surgery and the best options for your particular patient. But then don't forget to also assess the physiological status of the patient too. Is this patient at high risk of vomiting, regurgitation, or aspiration? If so, the patient will require intubation with an endotracheal tube and probably will require a rapid sequence induction and intubation. Then is the patient going to be a rapid desaturator? If so, then the patient will benefit from apneic oxygenation, early assistance of ventilation with a mask and bag technique while the patient is going off to sleep, and then possibly a more rapid sequence type intubation to secure the airway quickly too. You can also ask, does this patient have cardiovascular or metabolic factors that may complicate airway management? And we know that certain cardiovascular conditions won't tolerate hypercapnia or hypoxemia well, and metabolic acidosis in particular may necessitate a different approach to your induction and the speed of which you try to intubate the patient, and controlled ventilation so we can control the level of carbon dioxide more closely. Right, so now we're able to actually formulate our airway plan for this patient that's having the surgery. Next, we need to prepare our airway equipment in theatre so that we can fulfill this plan and manage complications that may arise. And so we prepare the airway trolley to cover as many of these scenarios as possible, not just the airway that you're planning. This then brings us onto our understanding of how we manage airways when we're having difficulty. And this requires a considered, in the forefront of your mind, understanding of an airway algorithm or an airway management approach. And the one that we went through in these talks was the vortex model as I think it's the simplest and most clinically applicable model. But there are other models, such as the models from the Difficult Airway Society. To recap, the Vortex model teaches us that as we fail at our attempts at airway management, and therefore oxygenation, we spiral down the vortex close to the danger zone that necessitates an emergency surgical airway. And this is because each attempt at airway management carries the risk of airway trauma, bleeding, and edema, which can turn a dangerous, difficult situation into a potentially fatal, can't intubate, can't ventilate scenario. Okay, so with our airway equipment prepared, our airway plan formulated, and with an airway management model or algorithm in mind, we can then bring the patient to theatre to perform the anesthetic. At the start of the anesthetic, we want to inform our team members if we are expecting airway challenges and communicate clearly with our anesthetic assistant what our airway plan is. For example, I could say to my assistant, we're going to do a rapid sequence intubation with a size 3 laryngoscope blade, a size 7 endotracheal tube with a stylet in situ, and with cricoid pressure. I would like you to do the cricoid pressure, please. If this doesn't work, I will mask ventilate the patient while you are still holding cricoid pressure. You may need to pass me the gum elastic bougie for intubation. If we have major difficulty, we will insert a size 4 i-gel supraglottic airway. So now my anesthetic assistant knows exactly what the airway plan is. It could also be a lot simpler. I could say to the assistant, I'm going to use a unique LMA size 5 for this case. If that doesn't work, then this patient is going to be a difficult laryngoscopy and intubation. So I would like the video laryngoscope in theatre with the D blade, so we can change our plan and we can intubate the patient. If this is the case, I will probably need the gum elastic bougie and will use a size 8 endotracheal tube. The point being, communicate so that your team has the best chance of assisting you to be successful. And then it comes to the actual induction of anesthesia and application of your technical skills in airway management. Here you need to be conscious of your technique. So for example, while I'm mask ventilating the patient, I'm thinking, where are my fingers? Can I feel that they're in the correct position? They're on the mandible, they're not on the soft tissue. Okay, am I really pulling up the chin? Am I really thrusting the jaw forward? Okay, right, that's a better technique. Okay, what are my airway pressures? How does the compliance feel? Right. I'm starting to get some air into the chest now. That's a bit better, but it's still not easy. What could be going on here? Is the patient too light? Is there some obstruction? Okay, let me gently insert an oropharyngeal airway. Okay, I'm watching the teeth, I'm watching the tongue. I'm trying not to cause trauma. The oropharyngeal airway is in place. Okay, good hand technique again. Here we go. Mask ventilation, a lot easier now. I'm happy. So the point here being, not just fulfilling an action mindlessly, relying on motor memory, but actually consciously thinking, what could be going on? Is my technique right? Am I doing it the best way that I can be doing it? And then lastly, from a technical skills point of view, you need to have planned for and visualized and be ready for that one time when you're going to need to perform a front of neck airway. And this requires role play in your mind. It requires watching teaching videos on social media. It requires that you palpate the necks of lots of patients. So just every anesthetic you do, just think, if I had to do a front of neck airway in this patient, what would I do? How would I do it? How does this feel? Can I actually tell where I would make my cut? Just be thinking about it and getting a feeling and know exactly how you're going to respond in that situation. If you can get to a skills workshop where you're working on a cadaver model or a synthetic model, then that would really help you in this situation too. Then lastly, for this talk, airway management doesn't end with intubation or ventilation. It ends with emergence and extubation and recovery in the post-anesthetic care unit. And so we've created another video in this series looking specifically at the wake-up or emergence from anesthesia. So that concludes this video. As always, I hope you found the content useful. Please contact us with questions and comments or suggestions. Good luck with your airway management and take care.